Welcome to The Explainer. Today, we're decoding the biology of fertility. Specifically, we're looking at the central hormonal network that actually makes human reproduction possible. Whether you're a med student or just kind of curious about the biochemical signals that literally dictate life itself, let's dive right into the human body's most intricate machinery.
So why are we talking about this? Well, check out this staggering number. An estimated 25% of women will experience infertility during their childbearing years. Yeah, that's 1 in 4. The stakes here are absolutely huge. This isn't just some niche medical topic, It's a profound human experience, heavily shaped by modern societal trends like delayed marriage, and, thankfully, an increasing acceptance of infertility as a totally treatable medical condition.
Here's our roadmap for today. We're going to cover 1. The fertility race, 2. The fragile hormone axis, 3. Causes of infertility, 4. The biochemical investigation, and finally, 5. Medical treatments and hope.
All right, section 1, the fertility race, a race against time. Fertility is quite literally a biological clock, right? But what's super fascinating is that some of the endocrine factors driving it are baked in from day 0, way before a couple even thinks about trying to conceive.
Now, to tackle the problem, clinicians have to establish a baseline. Clinically speaking, infertility is defined as failing to achieve a successful pregnancy after 12 months of regular, unprotected intercourse. But medical professionals draw a really important line in the sand here. Primary infertility, that means the couple has never achieved a successful pregnancy. Secondary infertility, on the flip side, means they can't conceive right now even though they've had at least one previous conception. This distinction is exactly how medical detectives frame their entire investigation.
Moving on to section 2, the fragile hormone axis, the biological network. To really grasp reproductivity, we have to pop the hood and examine the internal communication network driving the whole thing.
This right here is the ultimate medical detective's map, the hypothalamic-pituitary-gonadal, or HPG axis. It all starts up top with central signals in the hypothalamus, like kisspeptin, which fire off and trigger the release of GnRH. That signal travels down to the anterior pituitary gland, giving it the green light to release 2 absolutely vital hormones, FSH and LH. Those guys then travel all the way out to the peripheral gonads, so the testes in men and the ovaries in women, stimulating the creation of reproductive cells and the release of even more hormones, like testosterone and estradiol. It's just this incredible, cascading biological domino effect.
But here's the catch. The defining characteristic of this gonadotrophin axis is its sheer fragility. It heavily relies on these perfectly timed pulsatile feedback loops. So the secretion of GnRH isn't just a constant, steady stream. It's released in rhythmic pulses, which then triggers the pulsatile release of FSH and LH. If that rhythm is off by even a fraction, the whole system can just misfire. That's why measuring just one hormone at a random time of day is so tricky for doctors to interpret. Everything hinges on these continuous, ultra-delicate loops.
These chemical messengers all have super distinct jobs. You've got the instigators. GnRH acts as the master switch, while FSH and LH stimulate germ cell development and hormone production. Then you've got the responders. Testosterone drives spermatogenesis and male development, while estrogen and progesterone prepare and maintain the reproductive tract for potential pregnancy. And finally, there's prolactin. Now, it's mostly famous for milk production, but as we'll see, it's actually a massive player in fertility investigations too.
Which brings us to section 3, causes of infertility, when the system misfires. Let's look at what actually happens when this incredibly delicate system breaks down.
When the HPG axis fails to result in a pregnancy, doctors usually sort the suspects into 4 broad buckets: female factors, male factors, combined factors, or unexplained causes. Comparing the main culprits, we see that female factors usually involve ovulation disorders or structural issues, like tubal pathology. Male factors, on the other hand, can also be structural, like the congenital absence of the vas deferens, but they also include hypogonadism or even tiny genetic Y chromosome microdeletions. Basically, it's a pretty complex lineup of suspects for both sexes.
Focusing in on the female factors first, disorders of ovulation are usually the prime suspects. This covers conditions like anovulation, which is super commonly caused by polycystic ovary syndrome, or PCOS. It also includes something called luteal phase deficiency, which is just a fancy way of saying the body isn't producing quite enough progesterone to properly maintain the uterine lining.
But it's not all just hormonal misfires. Physical roadblocks can severely jam up the network too. Conditions like endometriosis or tubal and uterine abnormalities create literal physical barriers. They stop the egg and sperm from ever meeting, or they block the embryo from implanting. And honestly, if the road is blocked, it doesn't matter how perfectly those hormones are pulsing.
All right, Section 4, the biochemical investigation, tracking the suspects. We know who the suspects are, but how do medical professionals actually track them down in a clinical setting?
Well, tracking down the root cause follows a very structured path. It kicks off with educating the couple, moving right into a deep dive diagnostic workup, and then jumping into actionable treatment options. And honestly, maybe most importantly, because of the heavy emotional toll this journey takes, the entire process is anchored by continuous counseling and emotional support from step 1.
During that diagnostic workup, doctors basically become biochemical detectives. For women, when trying to confirm ovulation, timing is literally everything. Progesterone is usually measured on day 21 of a standard 28-day cycle. But here's a curveball. If a woman has a longer, say, 35-day cycle, testing on day 21 will give you a completely false read. The timing has to be adjusted to day 28 and repeated weekly until her next cycle starts. They'll also track FSH and LH to figure out irregular cycles and check AMH levels to predict exactly how the body might respond to IVF stimulation.
Now, for the male workup, the absolute cornerstone is the semen analysis, paired with a detailed physical history. But biochemically, the detectives are looking at some unexpected suspects here too. For example, they'll run a prolactin assay. Why? Because high prolactin can actually block the release of GnRH in men, causing secondary testicular dysfunction. They also test TSH, the thyroid hormone, because an overactive or underactive thyroid can seriously mess with sperm production and the way the body handles androgens. It's honestly wild how a completely different hormonal axis could just hijack your fertility.
And that leads us to Section 5, medical treatments and hope. Restoring the axis. Because once we find the exact misfire, we can take action. Let's look at how modern medicine can step in and fix this fragile network.
For male infertility, treatments are laser-focused on the specific roadblocks or hormonal dips found during the workup. If it's a structural block or an issue with sperm motility, surgeons can step in to repair varicoceles or reverse vasectomies. But if the issue is hormonal, like the pituitary gland just isn't sending the memo to the testes, doctors can completely bypass the brain. They just inject FSH and LH directly to artificially jumpstart sperm production. We are literally overriding broken biological signals. How cool is that? Over on the female side, especially for ovulation disorders, the medical toolkit is massive. It ranges from lifestyle tweaks to ovulation-inducing meds like clomiphene or metformin, all the way up to gonadotropin therapies. But one of the most mind-blowing treatments is for women with hypothalamic amenorrhea, where the body's natural pulsatile rhythm of GnRH just isn't happening. Patients can actually wear a tiny portable pump with an IV that automatically gives them a precise hit of GnRH every 90 minutes. They wear this for a week or two, literally perfectly mimicking the brain's natural rhythm until ovulation kicks in. It is an absolute marvel of medical engineering. All of this incredible investigation and intervention leads to a very powerful reality, captured perfectly by Dr. Meldrum. He notes that with thorough evaluation and the application of current treatments, like IVF, embryo transfer, or GIFT, 50 to 60% of infertile couples will conceive. And that right there is the massive dose of hope we want to leave you with today. Yeah, the HPG axis is fragile, but our modern medical solutions, they are incredibly sophisticated and seriously effective.
Which brings us to our final thought for this explainer. We've mapped out the intricate loops of GnRH, FSH, and LH, and we've seen how insanely precise interventions can literally outsmart biology when it misfires. So, as we keep decoding the human body's deeply complex biochemical pathways, what incredible new frontiers will reproductive science conquer next? It is a thrilling question to ponder. I hope this explainer left you marveling at the science happening inside us every single day. Thanks for hanging out, and keep feeding that curiosity.